everyone. This is Matthew Pavarnik here. I wanted to make a quick video on medical tests and COVID-19 because there could be a lot of misunderstanding behind them. Are your tests reliable? The answer actually depends. So I'm going to ask you a question here. So let's say you never had any symptoms and you weren't exposed to anyone that you knew had the virus. So if you got a good antibody test today and got a positive result, what are the odds that you actually did have the virus? So I'm going to ask this question if you were someone from New York City versus someone from Hawaii. Well, the answer is pretty surprising. The answer for New York City is there'd be about a 96% chance that that is a true positive result. So pretty reliable test if you're in New York City. But if you're in Hawaii and you got a positive antibody test, there would only be an 8% chance you were truly infected at some point. And this is the same test, mind you, just taken in two different places. So that's a pretty surprising result, and I'm going to break down why that's the case and how we can understand tests more reliably, how we can check for false positives or false negatives, and what this means. But first, I want to review very briefly the types of tests. So on the left here, I'm describing RT-PCR tests, which you can read what that stands for. But these are essentially looking for little bits of RNA from SARS-CoV-2. So it's a pretty reliable test. I'll show you some of the results for it here in a little bit, but it has its limitations. So one of the things is that this is testing for the active amount of viral particles essentially in your body, and it depends on the concentration. So if you test, say, too early, like I'll share an example of this a little bit later on, or if you wait too long. So, for example, on average, 7 to 10 days after your first symptoms, you might still test positive, but you might not. So if you wait too long, even this reliable test will give you a false negative, just simply because there isn't enough of the virus to detect in your body, but you're still potentially infectious. So then there's the antibody tests or serology tests. So that depends if you've previously been infected and your body has antibodies. So again, this has some limitations. It's very inaccurate. If you're just infected, it takes time for your body to produce enough antibodies to detect. So these are more accurate a good 2 weeks after you first have symptoms. And some could be useful for testing if you've previously been infected. There are ways you can do that. Or the CDC's test, as they say on their big serology survey or surveillance, they're not designed to test if individuals have been infected, but for the population as a whole. So how much of the virus is in large groups of people. So that's a really important question. So let's go ahead and break down some of the metrics or things that you might see talked about with tests. These are some useful terms to go ahead and discuss. So first, there's true positives. That's a pretty simple one. It's just someone who actually has COVID-19 and they test positive. That's a true positive. You could have a false positive, though. So you could have someone who doesn't have COVID-19 and they test positive for it. So we would like to minimize those. You can have true negative, so that's someone who doesn't have it and they test negative. So that's good. That's what you would want. False negatives can be a bad thing because that's someone who actually has the virus and they test negative and they think they don't have it because of the test. So that's why communicating to people what these tests mean is really important. And I'm going to try and unpack what some of that language means on if you get a negative test, if you get a positive test, so on and so forth. There are two metrics that are often reported on these. So there's the sensitivity and the specificity. So the sensitivity is related to the people or the percentage of people who test positive who are truly positive. So essentially, the higher this is, the lower the rate of false negatives. So that would be an important thing. So it's basically if someone actually has the virus, are they going to test positive? That's related to the sensitivity of this. But many things can impact the sensitivity. Like, for example, when the test is performed, as I just mentioned with the RT-PCR test. If you wait too long or do it too early, you're not going to be able to get a positive result for that. And then there's the specificity. So this is another important metric. So this is the percentage of people who test negative who are truly negative. So essentially, this is another metric you want. So you don't want to get false positives in there. You don't want people to mistakenly think that they've been infected. So how does this work out in this, and how do we get that? Testing can go horribly wrong. So some of you may have seen various media reports and so on and so forth, especially about antibody testing. And I think a lot of people have this idea that antibody testing isn't that reliable. And that could be true, but there are ways to improve its reliability, and I'm going to talk about that. So there were some exciting things that we were discovering. It's that there are actually a pretty decent percentage of people that are asymptomatic, but we were overestimating it by a big amount due to the limitations of medical tests. And this was really exciting thing. I mean, it's certainly awesome for an individual if you test positive for antibodies and you basically weren't even sick. That would be really great because maybe it means you have some immunity against the virus should you be exposed to it in the future. We're not sure about that yet, of course, but so let's go ahead and say that our test is 90% sensitive and 90% specific. Some of the early antibody tests were like that. And you say, oh, that's not too bad. Like, for example, the sensitivity is looking at if we go back, that's looking at, testing against, essentially, there's a 10% chance of getting a false negative and then a 10% chance of getting a false positive. So that's not too bad, right? Well, it sort of could be. So this is how it could go horribly wrong. So let me break down the math a little bit and show you that 90% accuracy on an individual test doesn't actually tell you what the probability is that you have the virus. So here's an example. In Hawaii, there's only about 100 infected people per 100,000 individuals. That is really, really small. So we'll go ahead and change that to a percentage, which is 0.1% prevalence. So essentially that's how many people are infected in Hawaii. So if you go ahead and you have 90% accuracy, what would you find? Well, out of the people who are positive, there's 100 of them, you will detect 90% of those cases, or you get 90 true positives. Unfortunately, 10% of the people who are infected will test negative. So you get 10 false negatives. So that's what that is. But the way that this goes haywire is because if you have a 90% accuracy, that's decent. But let's go ahead and talk about how many false positives you get. Well, the thing is that there are, let's see, this is 990, or no, it'd be 99,900 people are negative. Well, 10% of those are going to be false positives. And that means that so if you do this test, you would find 90 true positives and 9,990 false positives. So if you test positive, in this case, the odds that you had the virus is 0.9%. And if you test negative, the odds you never have the virus, though, is about 100%. So the thing is that whenever the prevalence is low, a negative result, you could pretty much rule out that you really didn't have it. But if you test positive, well, you really need to be careful with interpreting that result. So this is going to have to go ahead and do this. So this would be a huge mistake, and this is how testing can go horribly wrong. So you could overestimate the number of cases in your area by a factor of 100. That's kind of terrible. So how do we know this isn't happening in places? Well, we're going to get to that in, well, quite a bit. We have a little bit to go through. But let's say you had a better test. So this is a 90% sensitivity and specificity. So let's go have a better test. Here's actually a list of tests that have been approved for emergency use authorization. They're antibody tests. So I'm going to grab this one in particular. You can go ahead and follow the link and see, hey, what's the sensitivity and specificity of these tests? So I went ahead and grabbed this one. So in 49 samples, they had 0 false negatives, and in 400 samples, they had 0 false positives. That's really good. It's basically 100% accurate. But, there's still a chance that some error could occur. I mean, you didn't see any errors in 400 tests, or didn't see any errors in 49 tests. So, what can we make of that? Well, they give a confidence interval here. You see the true value of the accuracy of this test is somewhere between, if you look at the chart or the table down below, if you look at the specificity, it's somewhere between 99 and 100%. So that's good. It means you're not going to get a lot of false positives. But still, let's go ahead and apply this test to the Hawaii scenario. So if you do this, the results are a lot better. So, well, maybe not a lot better, but, well, I'll let you be the judge. So if you test positive instead of essentially, a 1% chance you actually had the virus, now there's an 8% chance you had the virus. So that's good. But there's still a 92% chance of a false positive. So that's bad. But now we're on to something. So this is one of the clues, of course, to getting better testing results. Is just simply making better tests that are more reliable. So now instead of overestimating the number of cases by a factor of 100, you're only overestimating it by a factor of 11. But 11 doesn't make people feel so good. So how could we still make this better? Well, one of the things that was interesting, if you recall from the beginning, is that in the New York City example, we used the exact same test, but the reliability of a positive result in Hawaii was only 8%, but in New York, it was over 90%. So how does that work exactly? Well, we got to talk about something else, which is the prevalence of a virus, how many people have it in a population, or in other words, we could talk about what can be called the pretest probability. So here's an example of that. So this is the percent that are infected in a population, and antibody tests are more reliable the more people that actually have them in the population. So for example, I just went ahead and looked at this here. If you look at 5%, for example, so if 5% of your population has been infected, you overestimate the total cases by 12%. So that's pretty good. Well, it's certainly better, but still you're overestimating cases. But once you get up to 20% closer to New York measures, you're basically looking at the measured number of cases basically equals the true number of cases. You still could be missing some, but at least you're not overcounting false negatives or false positives. But then once the percent infected gets even higher, then you can actually start undercounting cases. So that could be a bit of a concern. So now, in the top bit, whenever a small percentage of the population's been infected, you're more concerned with false positives. But once more people are infected in your area, now you're concerned with false negatives. So that's a pretty interesting result. So we're going to talk about this pretest probability and how you can get more reliable results by taking advantage of this metric. Another cool trick that you can do is you could do 2 antibody tests. And so in areas with low prevalence like Hawaii, so let's say you got tested in Hawaii, and the odds of you having antibodies before your test is 0.1%. But after getting one positive test, the odds of you having antibodies is actually 8%. But if you do a second positive test, the odds you actually have the virus is 90%. And so this is kind of a cool way that you can change the pretest probability. Essentially, you can test the same person multiple times. And that gives you some more confidence in this, even despite some of the initial limitations. But if someone just goes in a place where there wasn't a lot of COVID cases and they get an antibody test and it's positive, that's probably not going to be that reliable. So that's pretty interesting, but let's go ahead and skip over to RT-PCR tests. So how do those work? I've been basically focusing on antibody tests. So essentially they match some different sections of RNA, not DNA, it doesn't have DNA, it just has RNA, to SARS-CoV-2. So here are 3 different regions here, and here's a list of just different types of viruses. So if you had influenza, it would not show up on a SARS-CoV-2 test. So for example, there's influenza A and B you see there in the right table, and there's many other different types of viruses, different types of human coronaviruses, so like common cold, so on and so forth. And those wouldn't show up on an RT-PCR test. The only thing that actually showed up and matched one of the regions was actually SARS, severe acute respiratory syndrome coronavirus. And that actually matched the 3rd region. But it didn't match the first 2. So that's an important thing to know and pay attention to. But not a lot of people have, well, SARS. They have SARS-CoV-2. SARS is, not really circulating in the globe at all. So that's really good. This is good. Essentially what this means, the test is highly specific, and the rate of false positives will be very small. Somewhere essentially close to 0%. But what about false negatives? I want to share with you a couple stories of how you could go ahead and use these tests to determine if someone has the virus or not. So one of the things is that recall that this test, in order for it to work, you need to have a certain concentration of the virus in your body. That changes over time. So I've listed some statistics here. So basically, this RNA has been detected 1 to 3 days before you have symptoms. So you are likely infectious before you show symptoms. And the viral load peaks in the first week, but then it starts to decline. Um, and so essentially, here's a mistake though. So one of the things is that whenever you're infected, it takes time for you to actually show symptoms. On average, or the median, let's look at the median, it's 4 to 5 days from infection. So basically, here's an example, I think, to get this in across the people. So let's say you have coffee with someone and you spend a lot of time talking with them, close quarters, indoors, everything like that. They feel fine, you feel fine, no masks, you're good, right? Well, how about this? Let's say they get a positive test result the next day. And then you go ahead and get tested the day after that, and you get a negative test result. Now, does that mean you have COVID-19 or not? Well, the answer is you don't know. And here's the reason why. So the thing is that you were tested only 2 days after your exposure, but the median for showing symptoms is 4.5 days. So it's possible you don't actually have enough of the virus to detect yet. So that's one of the things about, the time from when you're infected to the time you actually see cases start rising and so on and so forth. So that's why if I go ahead and make a plot of, say, the number of positive cases in an area, well, that's not reflecting the true number of infections yet, because it takes time to detect new cases. So that's one of the interesting things in this little example. You could definitely test negative, but that doesn't mean you don't have the virus. It just means maybe you don't have enough to detect yet. But if you wait too long, there's too little viral RNA to detect. So, and false negatives are especially dangerous, just from a community standpoint, because it gives people, essentially, as I've written here, false assurance they don't have SARS-CoV-2. So here's, how can you make tests more reliable? So there are a few things. We've already highlighted some of the main things, but if you're gonna try to test if someone is actually actively infectious, there are a few things you could do to raise the pretest probability. So, for example, if you've ever done a COVID-19 test, you know that they ask you a series of diagnostic questions, right? So, do you have this symptom or this symptom? Do you have at least two of these symptoms? Do you have exposure to anyone who's sick? What about travel? Where have you traveled? So on and so forth. And that actually raises your pretest probability. So if you have a certain number of symptoms, or again, if you were exposed to someone. And so even if you have a small number of people in your area that are actively infectious, it's more likely that a positive result is a true positive. If you go ahead and have symptoms or exposure to someone. So that makes tests more reliable. Here's kind of a cool story of how you can actually roll out COVID-19. So this is a story taken from this article down here, but let's say there's this 73-year-old woman with severe chronic obstructive pulmonary disease, COPD, and a chronic cough, and she develops acute shortness of breath and slight worsening of her non-productive cough. She reports no fever, no known exposure to COVID-19, and no recent travel. She goes to an ER where she's short of breath. It shows possible infiltrates in a chest radiograph and so on, and she's admitted and placed in isolation on droplet precautions. So basically, if she has COVID-19, she's in isolation because her droplets are actively infectious and then requires intubation. But interestingly, whenever we do a COVID-19 test, it becomes negative. So what should we do in this case? Well, here's what ended up happening. It said, well, maybe she has community-acquired pneumonia. She doesn't have certain risk factors or clinical symptoms. And so, based off of all of her conditions, her pretest probability was estimated to be 50%. So there's about a 50% chance that she has COVID-19 before, given all of her conditions and so on and so forth. But whenever you get a negative test, you can actually reduce the probability she has COVID-19 to 24%. And then if you take another test, and let's say it comes back negative again, the probability that she has COVID-19 is less than 10%, despite her symptoms. So this is kind of a cool way that you can do multiple tests in combination and actually maybe rule out COVID-19. So when she was just treated with antibiotics, she continued to recover, and so it's probably likely that she never actually had COVID-19. So those are some ways that, if someone shows some symptoms, you can estimate their pretest probability, and multiple testing can help give you a more reliable method for figuring out who does or doesn't have it. So let's go ahead and look at Virginia Beach. it's more than 1% now, but about 1% of the population is presently infectious. So let's say that you go and you get a COVID-19 test. So if you have no symptoms, no exposure to anyone, your pretest probability is about 1%, that of the background population. Maybe even a little bit lower, but let's keep it at about 1%. You already likely don't have COVID-19. And if you test negative, basically it means you don't have it. But if you test positive, there's about a 50% chance that it's a false positive, and you should get a second test. So then you could go ahead and if you get a second test, that would go ahead and either confirm a suspected COVID-19 infection or not. But let's say you go to get tested, you have some symptoms, some COVID-like symptoms, or known exposure to someone who tested positive, and then your pretest probability might be 50%, like that case we just talked about, or let's say 75%. So then, if you test negative, there's still about a 10% chance, even with a highly accurate RCT-PCR test, that it's a false negative. But if you test positive, it means you have COVID-19. So that's one of the interesting things, and that's why it's really important to, that's why they ask you these questions. It helps them to interpret your results, and it helps essentially us to keep our community safer. So this is a lot of statistics and little potential situations, but it's really, really important, I think, in looking at this and people seeing test results and what do they mean. So just a little briefly, let's talk about wrong test results here for a bit more. So false positive, that's someone who's negative but test positive. How does that impact a individual? Well, it kind of stinks. You basically tell them they need to self-quarantine for 2 weeks unnecessarily. That's just unnecessary, and it causes a burden to them and their family and then everyone that they are in contact with. So we really want to do our best to make sure we don't have a lot of false positives. So again, designing better tests, doing multiple tests, and also pre-screening, all kinds of things we could do to help limit the amount of false positives. And then false negatives, those are very dangerous for the community. Essentially, when someone gets a negative COVID test, generally speaking, they're probably not going to go self-isolate for 2 weeks. And so this could be, and this is more of a concern, the more people in the community have the virus as well. So false negatives are particularly dangerous, and that's why many times, even if you test negative, but you had some symptoms or exposure to someone, they would still suggest, being careful and isolating for 1 to 2 weeks. But if there's low prevalence, you have no symptoms, no known exposure to anyone, then there's a good chance that your negative result is truly negative. So that thing. So here's kind of an interesting question. I've heard some people, just be concerned in general, like, what about false positives? Is it possible that these false positives aren't being overly reported? Like earlier on, I talked about. So I'm going to look at what would it actually look like from some of the metrics in COVID testing and so on and so forth. So, like in the first example, like with a somewhat accurate test, you could overcount the number of true cases by a factor of 100, and that would be pretty alarming, I certainly would think. So here's a few things. Again, just to cover, how could you lower false positives? A highly specific test. We looked at some antibody tests. Some others report 100% specificity. You're not going to get false positives in that. If it's 99.8% percent now, or PCR test, again, highly specific. So again, we have some really, really reliable tests that you're not going to, accidentally detect the common cold instead of SARS-CoV-2 with a more accurate test. The higher number of cases in an area, that would simply lower the proportion of false positives. Pre-screening, that can help lower the rate of false positives, and multiple tests on the same person. All of those can be used to eliminate false positives. False negatives are a concern because, again, how can that happen? Well, you get false negatives a few different ways. If you test too early or too late with PCR test or antibody test as well. So here's an example of what it would look like for false positives driving up positive cases. What would that look like? Going back to the Hawaii example. So if you do 1,000 tests, you would find 1 true positive and 2 false positives. So you would go ahead and detect 3 cases. 2 of them would be incorrectly diagnosed cases. And so that's the result that you get. So then let's say the next day you do 2,000 tests and you find 2 true positives and 4 false positives. So what does that tell you? Well, essentially it could tell you that, well, there were at least, a few more people in your area that had COVID-19 than you thought, but it means you're doing enough testing and there's not a lot of community spread. If you just simply scale up testing and cases go in proportion to it, then that's could generally be a good sign, unless you just simply aren't able to do enough tests. And that's why the test positivity is an important metric to look at as well. So 0.3 test positivity rate, that means you're doing enough testing and you don't really need to do more. And that's not really, you can't really drive up numbers with false negatives. It just simply, or false positive, excuse me. And so I just wanted to mention that this is a genuine real increase that we're seeing in the United States, or say in my local area of Virginia Beach. One of the things is that the pre-test probability is always greater than the random population. And the reason why is because most tests are done because someone has had a risk of exposure. You have symptoms. You're either a healthcare worker or a contact of yours tested positive. So those are some of the reasons people get tested. Some people are just done because their company requires it. But in general, the pretest probability is always going to be greater than the population at random. So that basically limits the amount of false positives. Basically, you can reject the concern over false positives. And the bigger concern, again, is false negatives. So that's why, even though these tests are pretty accurate, face masks are still recommended. And if you had symptoms, you should still isolate, even if you get a negative result. So. And other metrics are important too. So here, for example, I just went ahead and plotted the daily confirmed cases for my region here. This is with a 7-day moving average. I've added something to the plot. If you've seen it in my other ones, this one I've added on ER visits. And so for COVID-like illness, and these are weekly numbers. So that's in the orange graph there. So early on, there was a spike in kind of like in Marchish or so. And that was probably due to influenza and people maybe being concerned that they have COVID-19, but we had a very, very small amount of daily cases, like maybe 5. So if you have maybe 5 daily cases and a bunch of people going in for COVID-like illness, it's probably from influenza. But now we see the daily cases rising and we see an increasing number of ER visits. This is not necessarily hospitalizations, just ER visits for people with COVID-like illness. So essentially, this is how you could know that this isn't a bunch of false positives, because more people are going to the emergency room having symptoms severe enough to warrant going to the ER. And so that's how we can go ahead, and there are lots of different ways that we could look at these tests and their reliability and so on and so forth. But hopefully you learned something. This is way longer than maybe I wanted it to be or thought it could be, but I hope you enjoyed it. And let me know if you have any questions or if I made any mistakes, and I could go ahead and correct them in the comments. Thanks. Bye.